from tomorrow. Some common things I already showed you few cases. Always look at the eGFR and consider de-escalating therapy. When you go on a pre-mixed insulin or a prandial insulin, check whether you really need to continue your sulfonylureas in that particular patient, whether you can stop the sulfonylureas. On a similar note, when you start a patient on a GLP-1 RA, check whether you really want to continue your DPP-4 inhibitor. For whether you are using drugs like Soliqua or whether you are using a GLP-1 RAs like Ribelsus or Trulicity, the DPP-4 inhibitor should be discontinued. Consider modifying complex regimes to changing over them to simple regimes. When you need to intensify basal insulin, instead of going for a basal with prandial insulin, consider using a GLP-1 RA in eligible patients. Always the cost is an important consideration. Reconsider A1C and glucose targets in people who are older and those with comorbidities, and adjust or de-escalate therapy accordingly. Thank you very much.
Thank you, sir, for the very lucid presentation. In this context, I would like to ask one question regarding particularly the glucometer monitoring, self-monitoring by the patient. Do you think it has got any role?
Oh, absolutely. I think at least in my practice, which is mostly we see a middle class population, majority of our usage is still glucometers. We have still not moved on to significantly into continuous glucose monitoring. So it is still self-monitored blood glucose, and most of our patients who are on sulfonylureas, and almost I should say around 80-90% of our patients on insulin use self-monitoring regularly in their practice.
But it has to be taught to them.
Sir?
It has to be taught to them how to use that glucometer.
Yes, actually we have nurse educators who will sit with the patient, teach them. We usually give them a sheet to monitor, which all glucose to monitor, because that also can vary from patient to patient. Someone who is pregnant would require a 1 hour monitoring. Someone will require a pre-prandial monitoring. So that will be specifically taught to them.
Thank you, sir. Thank you.
Sir, while de-escalating, have you tried with the imiglamin?
In fact, no, sir. I don't have any patients on imiglamin.
Oh.
So when we detect a diabetic for first time or half the way in the treatment when the sugars are very high, like in the terms of 300 or 400, so especially in the new diabetic, would you recommend starting only with one drug like metformin and then slowly monitoring, or start with 2-3 drugs and then de-escalate?
So the ADA recommendation says that 9% or more with osmotic symptoms, preferably you start on insulin as the first drug. But then you see a lot of patients with more than 9% without osmotic symptoms. So when osmotic symptoms are not predominant, you really can reconsider whether you need to go on to insulin, or you can manage with multiple drugs, which can include metformin, a DPP-4 inhibitor with a SGLT2 inhibitor, things like that in combination. So if there is osmotic symptoms, then we don't go for SGLT2 inhibitor at the beginning. Otherwise, any other patient can go on to that. So what you see is that it's a newly diagnosed type 2 diabetes. Most patients will achieve control. And if you look at the AAC guidelines also, more than 9%, it's an indication for a triple drug therapy to be started at onset. So we don't go like metformin. That process is not there. You bang ahead initially with the best drugs that you have in your armamentarium, I would like.
Thank you, sir, for the enlightening talk. We now request our chairperson, Dr. Raghav Sharma, to hand over a token of gratitude to our speaker.
We now call upon our next speakers, Dr. Sahana Shetty and Dr. Praveen Kumar Devrabhavi, to talk on Treating the Trinity, Pioneering Optimal Outcomes with Oral Semaglutide, a duologue. We now hand over the session to our chairpersons.
Good morning. For the next session, I welcome Dr. Sahana Shetty, and she is Professor and Head of Department of Endocrinology at KMC Manipal with multiple academic achievements. And also we have Dr. Praveen Kumar Devrabhavi, and Dr. Praveen Kumar is professor at Department of General Medicine at Subaya Institute of Medical Science and Shimoga, and he is consultant endocrinologist also. Over to the speakers.
Good morning, everybody. First of all, I would like to thank Dr. Ganesh and the organizers for inviting us, and congratulations for a successful conference that's going on. So, myself, Dr. Sana, and Dr. Praveen, we are going to talk on treating the Trinity, pioneering optimal outcomes with GLP-1 receptor analog, a dialogue. This is the disclosure. So, in this talk, we are going to talk on the burden of the weight and cardiovascular risk in patients with diabetes. And then also we are going to talk on how important it is to address the weight and the benefits of weight loss in patients with diabetes and also in reduction of ASCVD. And then of course we're going to talk on how do we tackle this trinity of diabetes and the role of this molecule oral semaglutide in tackling the trinity of diabetes. So when we say epidemic, previously we were always thought about infection, but now when we say epidemic, we are mostly thinking of non-communicable disease. And we know several of the non-communicable diseases like diabetes, obesity are assuming epidemic and even pandemic proportions. So with this, let us try to understand from Dr. Praveen what is dual epidemic and how do the risk factors of these various metabolic diseases overlap, and what is this terminology, the unholy trinity?
Thank you, Dr. Sana. So we all know that the obesity and diabetes are dual epidemic, which is described by WHO because of increased incidence of both these factors. So if you look at the incidence of obesity in type 2 diabetes, almost 88% of people are overweight or have obesity at type 2 diabetes diagnosis. So it is said that even in India, if the patient have a normal weight at the diagnosis of diabetes, they are metabolically obese. 77% of patients with the type 2 diabetes across India have a HbA1c which is uncontrolled, which is more than 7%. So inadequate glycemic control and overweight is really a burden for us in management of diabetes. So there are overlapping risk factors for diabetes and obesity which end up in final common pathway, that is cardiovascular disease. In type 2 diabetes, we know that these are the risk factors. The main important risk factors are obesity, physical inactivity, and previous history of gestational diabetes. Of course, race and ethnicity is a very important factor, and all Indians come into this race which leads probably high risk for type 2 diabetes. Age, of course, the genetic factors in the background. And obesity, again, the sleep pattern. Sleep hygiene has become a very important factor for obesity. Socio-economic status, as the economic status of in India, it is increased in the last few decades. The obesity incidence is also increasing. The medication, particularly psychiatric medications, and these factors along with the physical inactivity, high blood pressure, age, lipids, etc., they are the common factors for both onset of diabetes and obesity. Obesity will lead to type 2 diabetes and type 2 diabetes have obesity. So in fact, if these factors, these common factors also are responsible for the final common pathway, that is cardiovascular disease. So type 2 diabetes and obesity and CVD risk factors are very common. So pathophysiologically, these obesity, diabetes and cardiovascular disease are interlinked. If you look at the type 2 diabetes, it is a state of insulin resistance and also it is a hyperinflammatory state. And insulin resistance will lead to hyperglycemia, and inflammation will also lead to, systemic inflammation will lead to finally dysfunction at the level of endothelium. There will be increase in the oxidative stress and atherosclerosis. On the other hand, obesity, we all know, particularly visceral obesity, which is again a hyperinflammatory state. It increases the all inflammatory factors in body and it causes systemic inflammation. Along with that, obesity leads to increased free fatty acid and triglyceride deposition, particularly visceral fat deposition will also lead to a dyslipidemia. Lipotoxicity is another reason why you develop insulin resistance and hyperglycemia. And also the pathway of renin-angiotensin gets affected in obesity and leads to hypertension. So if you look at these diseases, obesity, type 2 diabetes, they lead to a common pathway towards the endothelial dysfunction and atherosclerosis progression. And it will end up in what is called as atherosclerotic cardiovascular disease. So they are really unholy trinity, these diabetes, obesity and cardiovascular disease. If you look at diabetes and obesity, 88% of type 2 diabetes are living with either overweight and obesity. Look at the number of people of obesity, they are living with the diabetes. Any patient, 30%, the obese people who are roaming around have a 30% of them have a diabetes or pre-diabetes. So obesity, diabetes and cardiovascular disease. 32% of the people with type 2 diabetes have a cardiovascular disease. 50% of the death related to type 2 diabetes are related to cardiovascular disease. So that is the nexus between CVD and diabetes, and 29% of the type 2 diabetes, coronary artery disease who undergo angiography, angioplasty have a diabetes. And of course, more than 2/3 of death related to high BMI are again CV causes. More than 80% of the CAD are living with the overweight and obesity. So look at the cost expenditure. See, first of all, type 2 diabetes is a really economic burden because most of our patients spends in their pockets, which is not, most of them do not have insurances also in India. So already burdened with the cost of type 2 diabetes management, overweight will increase the cost again. So if the diabetes patient have a BMI between 25 to 39, we call it as overweight, the cost of therapy and the cost of living will increase by 11%. If they have a obesity class 1, the cost will increase by 17%. If the patient has a class 3 obesity, that is between 30 to 39, it increases by 29 to 30%. And the class 4, that is the morbid obesity, will lead to OSA, knee replacements, etc. The cost will increases by 46%. That is the healthcare cost you are going to have if the obesity and diabetes goes together. So looking at this obesity impacted on diabetes and increase in the cardiovascular risk, does early weight reduction have a severe risk reduction in diabetes? So Dr. Sahana, how can we target this weight early in whatever the drugs or the diets or whatever the methods we have in management of diabetes? What are the beneficiary effect of upstream approach, and how are the two recent trial which are direct and look ahead trial are relevant in this case?
Yeah, so what we know for sure is now is that obesity and especially the visceral adiposity is the main pathophysiological risk factor for any metabolic disease we're talking about, be it diabetes, be it dyslipidemia, be it MSLD, be it even PCODs, and all these ultimately increase the risk of ASCVD. So there are two aspects to it. One is we can think of weight reduction as a primary prevention where you could reduce all these metabolic risk factors, or as a secondary prevention where you have a patient with diabetes and then by targeting the weight, we would see significant benefit not only in terms of a good glycemic control but also reduction in the other cardiometabolic risk factors which usually is seen in patients with diabetes, and ultimately these together could result in reduced in ASCVD most importantly, and also overall reduction in micro and macrovascular complication. So let's look at the improvement we see with the weight loss. Now in this particular graph, you can beautifully see that how with the reduction of weight, even by around 3 to 5 kg, you see a steep reduction in the incidence of diabetes, and it drops down very significantly if somebody can lose weight of more than 10 kg and or even up to 15 kg, where we can see even remission of diabetes when there is more than 10 to 15 kgs of weight loss. Even 1 kg of weight reduction reduces the risk of diabetes by 16%, and that's the benefit of weight reduction, and that's why it's very, very important to address the ways when managing patients with diabetes, or even as primary prevention where we are counseling patients with pre-diabetes or those with risk factors for prevention of diabetes. And this here we see in patients with diabetes, you can see that how the HbA1c drops with a reduction in weight, and you can see even with a weight reduction of 2 to 5%, there is a significant drop in A1c, and the higher is the weight reduction, higher is the reduction in A1cs with just weight reductions, and of course the fasting plasma glucose also follows this curve. And then this is a very good study, that is the diabetes remission clinical trial, which kind of proved this concept of how weight reduction can actually lead to remission in diabetes. In this, there are two arms. This are the control arm and an intervention arm. There are strict weight management programs targeting at weight reductions. And then they categorize patients on the percentage of weight reductions and the amount of weight reductions, and you can see remission even with weight loss of around 5 kg, which was around 3%, and which actually even at the end of 2 years, 5% of these patients did have were in remissions. With the reduction of weight up to 5 to 10 kg, diabetes remissions can be seen up to 30%, and this number increases to more than 50% up to 10 when they lose weight more than 10 to 15 kg. So if a patient who can lose by at least 10 to 15 kgs, then you can expect that at least 50 to 70% of these patients can go into diabetes remission, and that is a fact. Again, the challenge challenge here is to maintain this weight loss or to sustain the weight loss, which becomes a challenge. However, in this particular trial where they have continued the weight management program, they did see the benefit of remission for up to 2 years. That's talking about the significance of weight loss. And for every kg weight loss, the odds of diabetes remission multiplies by 1.2 times. So greater is the weight loss, greater is the chances of going into remission. Of course, we all are aware of the glycemic control, but there's also a possibility of diabetes remission with good weight loss. Now moving to the look ahead trial again, which looked at the benefits of weight loss in patients with type 2 diabetes, and they targeted a weight loss of more than 10%, and they found that among the patients who lost more than 10% of body weight, 21% had this primary endpoint, which is a composite of reduction in CV mortality, non-fatal MI, non-fatal stroke, and admission to hospital with coronary events. And also the secondary endpoints, also you can see 24% reduction in patients who had more than 10% weight loss, which is mostly in terms of ASCVD events, recurring interventions like CBG, carotid endarterectomy, or percutaneous intervention. Again, talking about how weight reduction not only leads to improvement in glycemia, but also the macrovascular and AUCD events comes down significantly with reduction in weight, again emphasizing on the importance of weight reduction. Now, if you look at the other risk factors like hypertension and dyslipidemia, in the same study they showed that more the weight reduction, more was the improvement in parameters like blood pressure and dyslipidemia. So even 5% of weight loss following diabetes diagnosis was associated with improvement in risk factors, and there's a 48% lower hazard of CVD at 10 years. So you can see that higher the weight loss, higher is the or more is the gain in or improvement in metabolic parameters. For example, 5% weight reduction, definite improvement in hyperglycemia, hypertension. With 5 to 10%, again MSLD is coming in a big way, and we have seen that with 5 to 10%, there are clinical trials which have shown that 5 to 10% of weight reduction can bring about reversal in the pathophysiology of MSLD, even in PCOS and dyslipidemia. And also with 10 to 15%, 5 to 10% weight reduction, you could have prevention of diabetes, especially those who have impaired or pre-diabetes. Now with 10 to 15%, like we saw in the direct trial, there is a possibility of diabetes remission in more than 70% of patients. In addition to which, when we talk obesity, we talk of metabolic complications and mechanical complications. So when there's a weight reduction of more than 10%, you see benefits in mechanical complications, which is really bothering to the patients, like obstructive sleep apnea, osteoarthritis of knee, GERD, and even the MSLD. So that you also start seeing the metabolic benefits of weight reduction. And of course, with more than 15%, like we already said, diabetes remission is a possibility, and a significant improvement in cardiac mortality and heart failure has been documented. Yeah, with this, let us move on to the next agenda, that is tackling this trinity. Now here, let us look at the role of oral semaglutide. Is it able to address this trinity, what we talked about? And with this, let us understand from Dr. Praveen about oral semaglutide. Dr. Praveen, do you think oral semaglutide could be a game changer in this direction? And can you also talk about the clinical development program of oral semaglutide, that is a pioneer program, and then going ahead of the other OADs?
Yes. So before going to the oral semaglutide per se, about the clinical trials and all, so let us understand the structure of the semaglutide. See, the foundation stone of oral GLP-1 analog, that is oral semaglutide, is semaglutide. So it has got a 94% homology with human GLP-1, and the T-half, the half-life is 1 week. So why the half-life is 1 week? I am just going to describe it. So look at the structure. There are 3 modifications is done on GLP-1 here. One is the amino acid number 8, where amino acid substitution position 8, alanine to alpha aminobutyric acid. This substitution helps in the prevention of degradation of this GLP-1 by DPP-4. You know that half-life of GLP-1 is only few minutes, because of the DPP-4 enzyme destroys this immediately. And there is one more modification is done at the structure 26. At the position 26, again the C18 fatty acid spacer is given at the position of the lysine. So this helps in binding this particular molecule into albumin strongly, so that half-life in the our body is prolonged. So and again at the structure amino acid position 34, the lysine is replaced by the arginine, so that this spacer do not bind to the position 34 of the lysine. So it has to go and bind to the only position 26. So it is a low molecular weight GLP-1. The molecular weight is low and it helps because the molecular weight is very important, because if the higher the molecular weight, they doesn't cross to blood-brain barrier very easily. Lower the molecular weight, they cross the blood-brain barrier. So this is very important that this molecular weight is the impact on the weight reduction, because finally the appetite suppression occurs in the brain at the level of hypothalamus. So this is the structural modification. Because of this structural modification, the half-life of this molecule from few minutes prolonged to 1 week, that is 160 hours. So you know that these GLP-1 cannot be taken orally because they are peptides. The peptides are easily hydrolyzed by the enzymes in the intestine as well as the acidic pH of the stomach. So what are the modifications to be done if this has to be absorbed from the stomach or intestine? So there is a technology called as SNAC technology. So why this technology? There are a lot of efforts, research, so that this peptide gets absorbed. So there is a SNAC is nothing but sodium N-hydroxybenzyl aminocaprylate. This particular molecule protects the semaglutide from breakdown by the gastric enzymes and also allows the semaglutide to be absorbed from the stomach. Semaglutide gets absorbed from the stomach. If the semaglutide orally, if it is given without SNAC, only 0.001% gets absorbed. If the bioavailability of the semaglutide has to be increased, then we have to give this a particular SNAC technology, SNAC along with the this GLP-1. So this is the semaglutide here, the SNAC. The SNAC forms the coating around this semaglutide and increases the pH of this semaglutide around this semaglutide, so that gastric pH doesn't destroy the semaglutide. So the weight which is prescribed or recommended for co-formulation of oral semaglutide with the SNAC is around 300 milligram SNACs, and the co-formulation doesn't change the chemical structure of either semaglutide or SNAC. So oral semaglutide undergone clinical programs. There are 19 clinical pharmacological trials it has undergone, very expensive clinical trials. Lot of efforts are done to study this oral semaglutide in human. The phase 2 trial was a dose finding trial. Phase 3, there are 12 phase 3A trial and 1 phase 3B trial. So 11,507 subjects were enrolled in this trial, and around 6,645 were exposed to semaglutide. A large number of population diabetes patients were. These are the pioneer trial, that is peptide innovation early treatment of diabetes program. This pioneer 1 is a monotherapy, that is a oral semaglutide 3, 7 and 14 milligrams are compared with the placebo in a drug naive patient to find out the reduction of HbA1c or efficacy. Pioneer 2 is when compared to SGLT2 inhibitors, oral semaglutide 14 milligrams to empagliflozin 25 milligrams in a stable dose of metformin for a period of 52 weeks. Then comes Pioneer 3 that with DPP4 inhibitors, oral semaglutide 3, 7 and 14 when compared to sitagliptin, the advantage and disadvantage of this over DPP4. Oral semaglutide also compared with the other GLP, injectable GLP, that is a liraglutide, well established in the market with the background of metformin. Pioneer 5, oral semaglutide with a placebo for a renal impairment patient to find out the safety and to understand the safety of oral semaglutide in a CV patient, that is a CV outcome trial or a CV safety trial, that is Pioneer 6. And Pioneer 7, the dose adjustment, and Pioneer 7 extension trial along with the sitagliptin switch trial. That is, you start with the oral semaglutide with sitagliptin and switch over to a combination of oral semaglutide with sitagliptin or semaglutide alone. These are the various programs which happened with the Pioneer. So what is the HbA1c reduction with all these trials together, oral semaglutide versus a range of comparator of Pioneer program as a monotherapy with empagliflozin versus sitagliptin or even with the liraglutide and insulin. The oral semaglutide has scored over these and the HbA1c reduction is 1.5%. It is said that in the post hoc analysis of this Pioneer program, your basal HbA1c, if it is more than 9.6, HbA1c reduction is almost 2.6%. So among the oral hypoglycemic agent, the strongest in HbA1c reduction is oral semaglutide. The oral semaglutide in the weight, this is the most important part which we are talking today. The weight reduction is, average mean weight reduction is almost 5 kg when in all these trials together. So a threefold greater loss of mean fat. If you look at the weight loss of 5 kg, what exactly the weight loss is? Is it a fat or it is a muscle mass? The 3.5 to 4 kg is the fat reduction, only 0.1 to 1 kgs of muscle reaction, this lean mass is reduced. So in a body composition, is predominantly it is a fat which is reduced in oral semaglutide. Again, exposure response relationship is similar to oral or subcutaneous, irrespective of the route of administration, whether you give subcutaneous or oral. The amount of HbA1c reduction at the level, blood level of this particular semaglutide is same. So, semaglutide reduces body weight through the appetite. You can see that energy intake during ad libitum lunge, those patients who take oral semaglutide, they reduce they take around 2000 to 378 kilojoules. On the other hand, placebo 3000 to 600, almost 1000 kilojoules less. And semaglutide and placebo scored, the semaglutide scored better in questionnaires. That is, the craving is reduced, the eating control portion size is reduced, without feeling the meals are unpleasant. They feel meals is pleasant, but the calorie, everything is reduced. So it reduced the waist circumference when compared to even empagliflozin. You can see that the waist reduction is better with the oral semaglutide. Now the cardiovascular safety. Everybody is talking about cardiovascular safety after 2008. So semaglutide has shown in Pioneer 6, it is an event-driven 14 milligram semaglutide with the background standard care of therapy with compared to placebo. It has shown that there is a 21% reduction of the MACE, and confirming that it is as safe as a placebo in a standard case of therapy. So oral semaglutide is really beneficial in plasma lipids reduction. It reduces both triglyceride and LDL. And when compared to the placebo, it has reduced around 2.7 millimeter of mercury of blood pressure. These two things will really helpful in cardiovascular protection. Probably, though it has not shown the cardiovascular protection, only cardiovascular safety, the duration is, you can see, 1.3 years. If the larger duration, the sole trial which is going to come for semaglutide probably will answer this, whether they are cardioprotective. So after these, so much advantages of reduction of weight, cardio safety, and lipid protection. Dr. Sana, how does the data fit into Indian scenario?
So I think the molecule is there for clinical use, and all of us have been, using the molecule for quite some time. And as we saw in the Pioneer trials, and that's what we see in clinical practice also, that we see a very good glycemic control with A1C reduction of more than 1 to 1.5%. But the main advantage of the molecule, of course, is the weight reduction, where we have seen weight reduction ranging from 5 to 10 kgs, in some patients even more than 15 kgs. But importantly, the benefit is that the weight loss which is achieved is sustained, that initially for first 3 to 6 months they lose weight and then they do not regain, and that's the main advantage if you're able to continue the molecule. And of course I spoke about how with weight reduction we do get benefits in other metabolic parameters and also the mechanical complications of diabetes, and this is what we see in clinical practice also. When we say GLP analog, usually we are concerned about the adverse GI adverse events, but although this is also oral as compared to the others which are injectable, somehow we see that the incidence of GI adverse effects is significantly less as compared to the injectables which we're using. That's the clinical experience what I've seen. And many of this Pioneer trial did have Indian patients as Indian representation in these trials and did show similar results. Now, the real-world evidence study on oral semaglutide is ongoing on Indian patients, which is known as Pioneer Real India study. They're recruiting patients, and these patients are being followed up for 34 weeks. And ultimately, they're going to look at the glycemic improvement in terms of A1C reductions and also reduction in body weight and proportion of patients who would achieve A1C of less than 7%. Now, the study is ongoing, so the results are yet to be out. Although the baseline characteristics was presented in the ESICON 2023, and when you look at the baseline characteristics, the A1Cs at which these drugs were started, because the real world evidence study, this will also help us in understanding the prescription pattern correctly in India. So the mean A1C was around 8.9%, and 90% of the doctors who started it quoted that it was started for glycemic control and most importantly for weight benefit. And also interestingly, you see that in 1 out of 5 patients, it was started within 1 year of diagnosis, suggesting that a lot of people are placing it early in the treatment of diabetes, that is patients in the early stages of diabetes we are using, mainly because I think when we see young patients with hyperglycemia and obesity, we are mainly targeting weight reduction in these patients because we know that there will be significant benefit with that. So starting this early in the diabetes helps. And also, 1 out of 2 patients who received these drugs had some history related to cardiovascular, either cardiovascular risk factor or established cardiovascular disease. That was a prescription pattern in India. However, the outcome of this study or the results of the study is awaited and will soon be published. So with this, we would like to summarize that, of course, we have robust clinical data, and of course, many of us have clinical experience about the glycemic efficacy of molecules showing a good A1C reduction of more than 1 to 1.5%. And most importantly, clinically relevant weight loss, and that is through central action to reducing appetite. And also, although we were aware of the GLP-1 and its benefits, the parenteral formulation was a limitation. But now, with the available of oral drug, I think more and more patients will be able to get the benefit of this therapy. And of course, as of now, we have the cardiovascular safety, and then the cardiovascular benefit data is for the injectable. But then soon we are also looking forward for the solo trial, which might give more insight on the cardiovascular benefit of these molecules. And of course, we talk about how it targets the various cardiovascular risk factors, not only by weight reduction, but also hypertension, dyslipidemia, and other factors. And another important thing is that no dose adjustment would be required in renal and hepatic impairment. Of course, we would be cautious in not using in patients who have already having nausea, vomiting in a CKD patients. But otherwise, dose modification is not required and it's safe to use. And again, an interesting, another important property of the molecule we know is it does not cause hypoglycemia. Again, encouraging her to use early in the stage of the disease. And also, to get the benefit of this molecule, we know that it's a peptide which is present in a pill. So the right administration is very, very important. It has to be taken first thing in the morning with 120 ml of water, and 30 minutes fasting post dosing becomes very, very important. Now, this instruction must be given to every patient, because if this patient does not follow it, then we're not going to see the benefits of the therapy. I think with this, I would like to end the talk, and Dr. Praveen would be happy to take the answers.
The last this one, Madam has explained. It should not be taken in a large amount of water also, because the molecule should not move into intestine. It should remain in the stomach. That's why the 120 ml is set.
The dais is now open for discussion. In your experience, how many percentage of patients do continue it over few months or at least 6 months?
Yeah, good number of patients I think those who have lost a good amount of weight are actually motivated to continue the medications. Hardly any patients have discontinued because of adverse effect. Of course, because of the cause, there might be some concerns about continuations. Otherwise, with respect to efficacy, adverse effect, I think we have not seen any discontinuation of the molecule.
Yeah. So when we are starting this patient, most of the time it is those patients who are very affordable, then only we start it. And we tell them, this is the cost going to be, this is the yearly cost going to be, this is 3-year cost going to be. So those patients who are intolerant, mainly the GI intolerance is the most important factor. If they do not tolerate it, then only they discontinue. Most of them, particularly obese patient with the diabetes, they are very happy to take this patient.